So thanks everybody for attending a new Bytes of Innovation webinar. My name is Martin Willemink. I'm co-founder and CEO at SecMed, and I'm proud to now to present or to moderate this next Bytes of Innovation webinar. So what is Bytes of Innovation? We provide a deep dive into the future of medicine, and we do this with renowned experts such as researchers, physicians, investors, and lawyers. We usually do it every other Thursday. And the idea is 15 minutes of presentation by the expert, and then we have 10 minutes of Q&A, which is moderated by Aline Lutz, our Senior Medical Director at SecMed, and by me. So to all participants that are here, make sure to put your questions in the chat box so that during the Q&A phase, Aline and we can discuss them with our presenter. And today, I'm proud to announce that we have Dr. Ryan Lee amongst us. Dr. Lee, he graduated from Cornell University with a Bachelor's of Arts, and he obtained his medical degree at Drexel School of Medicine. And he completed his residency in diagnostic radiology. And after that, he became a neuroradiologist by doing his fellowship in neuroradiology. And on top of all of that, he also holds an MBA from the University of Rochester. So currently, Ryan is an associate professor at the Thomas Jefferson University, and he's also the chair of the Department of Radiology at Einstein Health Care Network. His areas of expertise include radiation management in imaging, radiology clinical decision support, and MRI safety. And moreover, as an authority on quality in radiology, he also serves on several quality and safety committees within the Einstein Healthcare Network. And today, Dr. Ryan Lee is going to talk about radiology, AI, and the future. Ryan, the floor is yours. Let me unshare my screen.
Great. Well, thank you again, Martin, for having me. It's a pleasure to be here, and I'm going to talk a little bit about, I guess, my experience, our experience here at Einstein in AI, and where we think that it's ultimately going to go in the field of radiology. I have this slide here that describes, I think, what the modern radiologist is responsible for. You know, traditionally, people think of radiologists as somebody who looks at studies, creates a report, and that's the end of the responsibility. But the modern radiologist, and this is a concept really that has really been promoted by the ACR, some of you may have heard of Imaging 3.0, is that really we should be much more comprehensive from beginning to end of taking care of a patient once they enter the radiology cycle. So that begins from ordering and scheduling patients to protocoling the studies correctly, acquiring the studies, and then finally the traditional role of interpretation and reporting. And more recently, a lot of attention has been directed towards communication, and that the report's no good if nobody sees it. And so the communication is really an extremely important part of what a radiologist does. And finally, to close the loop, to make sure that we are continually improving quality and trying to improve ourselves in the peer review. And so the modern radiologist has a lot to think about. And the really interesting thing is, I think when we think about AI right now in the space of radiology, we think a lot about the interpretation. And what I'd like to talk about today is, in addition to the interpretation, some of the other things that AI can be useful for in the radiology space. Because I think some of these other things that AI can do in many ways can be transformatory compared to even the traditional pixel-based AI algorithms that we talk about. And as many of you probably know, there's so many algorithms that are available now in the radiology field, the so-called pixel-based, and making diagnoses and for triage applications. This is just a sampling of the current, some of the current offerings we have here at my institution. And certainly you can see that there's a wide variety, and there's certainly even more in the space that are available, and many different vendors sort of in the same space, many different lung nodule detection algorithms, many intracranial hemorrhage algorithms. So we definitely are not lacking for algorithms. The question is, when we talk about the future of radiology and AI, once we have, many places will have some of those algorithms and perhaps even more. And at some point, it becomes difficult to remember where all these algorithms lie as a radiologist. You can imagine if you have multiple widgets on board on your desktop, or you have some algorithms that are deployed perhaps in a certain window and some in another window, it can be confusing to keep track of all the algorithms. So one of the future states, and it's not necessarily future because we have a lot of things right now to this, is dealing with how can we make this a more homogeneous experience, right? We have limited real estate. Many of us have 2, 3, or 4 monitors, but it's all taken up, a lot of it by the PACS and some of it by dictation. And so where you deploy the AI is going to be important because you're dealing with the remainder of the limited real estate. And because these AI algorithms may all function a little differently, they all might be deployed a little differently as well, especially when you're dealing with an individual vendor. And so as a result, it's going to be hard, as I mentioned, to keep track of all these algorithms. One thing that is probably less talked about when deploying AI is sort of the back end issues to think about. And when you deploy AI algorithms independently, well, you're talking about vendors that are interacting with your PACS and IT team, and each one of those may have different requirements, and it can be very onerous for your PACS or IT team. And on the back end, for those of you that may be dealing with the contracts, you can imagine if you have 7, 8, 9, 10, 11, or 12 algorithms, and 7, 8, 9, 10, or 11, or 12 contracts to deal with, that is a lot of contracts to have to review, a lot of legal services that have to be reviewed, a lot of security concerns that have to be reviewed. And so that can add up over time as well. So what is one way in the future and even in the present, as we're versioning, that you can deal with some of this? Well, you can imagine just taking the example of your phone that you have in your pocket. There are different platforms, right? The common ones are iOS that Apple has, and another one is Android by Google. And those are the dominant ones, but certainly there's some other platforms in the mobile phone world. But what do they have in common? In order to play in their space, each of these platforms requires the apps that live on there to conform to certain requirements so that they can be deployed more homogeneously and really translate to an easier user experience, since the user is expecting a certain way that the things look on their screen and how they deploy. It's a little bit of a more uniform experience. And so we can take a lesson from that with how we deploy AI algorithms. And there are many different ways I think that this can be accomplished. I'll talk really quickly about 3, I think, dominant ways, and there are certainly other ways to do it, but these are 3 of the more dominant ways that are developing in the radiology space. This first one here is a natural one in your PACS, right? You're staring at the PACS as a radiologist 90% of the time. So having your algorithms deploy within the viewport of whatever PACS system you use is an obvious space, right? If you have a uniform way of displaying it either in the work list, in a secondary window the PACS has, or within the viewport itself that you can interact with, you can imagine that would be a very homogeneous experience. And so that is a natural way to think about. But another way could be through your dictation system. And so with your dictation system, that's the second most common thing that you're probably looking at. And if you have as a platform the algorithms that are deployed through your dictation system, well, you now have a homogeneous way, one, but you also have perhaps input into the outputs of how they're going to be put into the report itself. And so that has its advantages. As we continue to have more vendors in the space, some vendors are getting so large that you can consider themselves a platform. So if you have a widget from a vendor that has a lot of different algorithms and they're all deployed in the same way, whether it's a window or a widget like this, you can imagine you can consider that a platform. And the radiologists, no matter how they're interacting with in each of these 3 spaces, know that the algorithms will come through there. And so there's some consistency in how it's deployed, which will allow better interaction between the algorithm and the radiologist, and ultimately better usage and perhaps better functionality. So what are some of the take-homes I wanted to talk about in terms of a marketplace or a platform? One, uniform is, as I talked about, which leads to an ease of use because you don't have to think about the different ways in which it might be there. If it's in a window, in a widget, on the PACS or whatever, that you have one primary way that makes it much easier to interact with. Those of you on the backside that deal with the administration of how it's actually deployed will know that if you have a platform that houses all these algorithms, it is much easier for your internal PACS team to deploy because a lot of it is coming through the platform anyway. So it's just a matter of making sure the appropriate port is turned on. And on the contracting, having one master agreement that allows the addition or subtraction of the algorithms, I can tell you from personal experience, can significantly decrease the amount of work you have to do on that end. But I'd like to talk about some other things, which I believe the future of AI is headed. And we have things already, and I'd like to talk about some of those, but we're just at the beginning, just as we're, I think, still at the beginning of the pixel-based AI. There's a lot more we can do. There's a lot more on the non-pixel-based AI, workflow and logistic type applications of AI that can really transform how radiology is ingested and ultimately delivered as healthcare to the patients. So starting all the way from the beginning, from ordering and scheduling, many of you may be familiar with the concept of CDS, clinical decision support. We're supposed to have it in our systems starting in January 1, 2023, but that currently may be delayed once again. But the whole concept of clinical decision support is that it gives ordering providers a tool for which to robustly decide what's the most appropriate study to order. Now, some of these CDS mechanisms have started to employ using AI to help generate better results. And how can that be? For example, if you had visibility on what's going on in the EMR as you're ordering a study, so that's not a static thing, but we're taking all available information using NLP and other tools, perhaps we can get to a better study that we ultimately do. And so there's a lot of room. Some of the CDS software is already starting to use NLP to some degree to recommend studies, but there's still a lot more we can do in order to tap all of the available information prior to ordering a study. And even with scheduling, how do we schedule patients? There's software out there that looks at your radiology, your workflow, and the list of patients coming up. Perhaps you have in your institution scanners, for example, if it's in a hospital that does both outpatients as well as inpatients and ED patients. And so you might have outpatients that are scheduled, but if an emergency comes in from an ED or inpatient, the technologist just has to make that outpatient wait. What if there's a way using real-time refocusing and rescheduling of patients to minimize the amount of time that a patient has to wait, and also give them a little bit more clarity and say, hey, Mrs. Jones, we unfortunately have an emergency. We'd like you to come back in 15 minutes and we'll be ready for you. Imagine having that kind of visibility for patients. And so they are hopefully a little more satisfied in not having a start time when their study was delayed. So lots of opportunity there. And you can imagine the efficiencies that could be gained in employing software like this. And there are startup companies that are starting to look at this. Some that we're engaged with here at my institution. Going back to the ordering, we use the CDS currently really to decide what's the most appropriate study to order based on the input of what was originally ordered by the doctor or the advanced practitioner. But what if we use CDS and using AI, but even in this model, what we did here, use CDS to actually talk about what if we should order the study. Not what's the most appropriate study, but assuming we have the most appropriate study, whether we should order it or not. This is an example of an algorithm that we deployed here at my institution specifically for minor head trauma in pediatric patients. And this is based on a very well-known paper that came out of, it's called PCARN. It's an emergency society that looks a lot at pediatric issues. And they came up with a relatively simple algorithm for how to decide if you should order a head CT or not in the context of minor head trauma. And the whole idea was to reduce unnecessary utilization. So what we did was we actually wrote a little subroutine within our CDS to decide after a few clicks, as you see here, to let the ordering provider know whether they should. And in this case, after putting in a few clicks, that it comes back that CT of the head is appropriate, and there's about a 4% chance using the PCARN criteria that there could be a positive finding. And if it's not appropriate, it would say that and still give the ordering provider the control whether they still want to do it or not. You can imagine if you got a little more sophisticated, because this is simply a manual process that the provider has to do. If we used NLP to mine the appropriate data in that's already in the EMR, maybe we already know what the best eye response is. We should be able to find what the age of the patient is by defined fields. Maybe we can mine the data to figure out the mental status and vomiting, et cetera, using NLP, that this could be a much more automated process and give the recommendation immediately without having these additional clicks. This could potentially reduce utilization even more. When we did this at our institution, we actually found, we presented this at RSNA several years ago, that we reduced CT brains I think by about 15% or so. So not a staggering number, but you can see where the potential could be. We talked about the scheduling of patients, but what if we can use AI to help us in scheduling of radiologists? Imagine if you have a large group, say 100 or more, that you can deploy radiologists to various sites, but using data such as time of year, historically what the volumes would be, weather. You can imagine all kinds of inputs that could be very useful to deciding, hey, at this time of year, we notice that those 3 locations are typically lighter. We don't need to staff it with as many radiologists, but at our other sites, it's heavier, that we should staff more. Imagine a scheduling software that can intelligently schedule radiologists based on those kind of inputs. That would be a much more effective and efficient use of where we should have people reading based on all these other inputs rather than just a static schedule like you see here. So lots of room to grow, and there are companies that are doing that there as well. We have lots of software. Well, I would say lots, but there are certainly companies out there that maximize signal to noise, to improving the signal to noise based on advanced deep learning algorithms in MR and also CT. Those are starting to get more common, whether they're third-party vendors or they're from vendors that are from the scanners themselves. That will continue to improve quality, and also potentially, if you're talking about MR, you have the choice of improving the quality of your study or decreasing the scan time. And so perhaps a combination of those can improve your workflow and or your diagnostic capability. So as those become more online, I think we'll see even better radiology images or better turnaround time. There are companies out there that also help with reporting, and specifically in report generation. And I can tell you that we use a software like this, and it has, although we have not yet proved turnaround time decreases, only because our workflow, I think, is quite complicated. We have residents running around, and so obviously that would increase our turnaround time. And how do you subtract out that variable? But I can tell you for the radiologists that are constantly using it, the burnout factor and the mental wellness has been significantly improved. Not having to repeat things twice in a report, it is really quite an experience, and can contribute to the productivity and effectiveness of radiologists producing reports. And how good does it work? Well, we actually, a couple of years ago, we presented an abstract at RSNA actually showing that there was no difference when we blinded radiologists to actual impressions that were generated by radiologists versus impressions that were generated by this algorithm, because this algorithm takes into account the old studies and learns your style, and also takes into account the history and the body of the report of the findings that you put in there. And it's amazing how well it's able to duplicate the style of the radiologist in question. So it's quite a remarkable piece of software, and there are several out there. And you'll notice I've gone out of my way, actually, specifically not to mention vendor names, because I think there are multiple different vendors playing in all these spaces. It's an exciting time, I think, because there's so many different options. Closing the loop. This is something that has really picked up traction in the past couple of years, and this is really the communication aspect. It's great to generate a report, but in times past, how do we know that the appropriate people, whether it's patients or the ordering provider, are actually getting the information? We can generate the best report in the world, but if they don't know about it, what's the point? And we're now at the point with technology that we can actually track some of these things and perhaps give some feedback to close the loop, and ensuring that the appropriate people are getting the study. And if they're not, make sure that they do. We collaborate with a startup vendor that has helped us mine reports, and those reports that have recommendation for follow-up imaging, we actually send notices to the patients. And what we found retrospectively when we did this was that we were able to have patients complete studies at about a clip of 9 to 10% better than they were before we started this follow-up. And that was a retrospective study. So based on that, that's a relatively modest, I think a modest improvement, but an improvement, and that was statistically significant. We conducted a prospective study where 2/3 of the patients would get the notification and 1/3 would not. And we started this actually back in January. And what we found is that we've had a 25% better completion rate of studies using this tool, which basically uses NLP, a combination of NLP and then notification tools that alert the patient. So you can see this is just a space that's beginning. We didn't really have technology like this 5 or 6 years ago in order to close this loop. But because we now do, I think this is a great time to really start paying attention to closing the loop and making sure appropriate people are notified about these examinations. Peer learning. Many of you probably use a traditional rad peer version where we ask radiologists to review studies and see if there's any discrepancies. We agree with the study, or if there's a minor discrepancy or major discrepancy. We found at our institution and many institutions, there's been literature written about this, that actually that doesn't work out so well, that people just kind of do it to get things done. And so more and more people are starting to do peer learning, in which we don't ask them to do as much, but we ask them to look for studies that have learning value. And so we're not necessarily trying to look for the number of discrepancies people do, but looking for discrepancies for an educational purpose. And what we found, and this is the peer learning workflow that we have at our institution, where we break it down to subspecialty, then have a committee review it, and then we'll actually review it for M&M. Feedback we actually received was that it actually, even though you asked them for a lot less reviews, so we used to ask for 25 in 6 months, now we actually ask for only 12 in 6 months, that the bar was set higher, because these peer learning examples have to be good from an educational point of view. And the feedback we got is, hey, actually, it's a little bit harder. What if we employed some of these algorithms, not in real time, but retrospectively, to present to radiologists, so that we're giving them some additional opportunities to present for a peer learning, because we do require the peer learning as part of our OPPE process in our institution. So that's something we're investigating. There's some hurdles to overcome. Looking at things retrospectively has its own set of challenges, but that could be another way that that AI tools can be deployed. In the population health scheme, there's so much that we can do in the future, and a lot of this that we're starting to do now at our institution. And it used to be called the triple aim, but really people have moved more to the quadruple aim, talking about the experience of the provider, and that we really have to pay attention to the burnout of the providers, of radiologists and other healthcare practitioners. But what can we do in the population health realm? And we're just at the very beginning. One of the first AI algorithms to get a CPT3 code is bone demineralization. There are coronary artery calcification algorithms out there. There's lung nodule applications, and even AAA algorithms out there. These are things that we have collaborations with, and we do these with other services: pulmonology, cardiology, rheumatology, and possibly outpatient clinics in the case of AAA. But if we are able to use these algorithms in a preventative way, coronary artery calcification, for example, these are in the past probably not robustly always reported by the radiologist. What if we're able to take this information that is incidentally found in many cases and automatically send to cardiology for possible consult? Maybe we keep these patients out of the ED because they don't have a heart attack now, because we're prospectively managing. Same thing for bone demineralization and AAA. These are all preventative healthcare things that we as radiologists, we in the field of radiology, can provide this preventive care before they use acute care services. So lots of room for growth. Very exciting, I think, as more of these algorithms come online. I think I went way longer than I was supposed to. So I'll stop right there. I just wanted to give you a glimpse of some of the places I think that AI can go in the future.
Thank you, Dr. Lee. No problem. It was so interesting. We have already many questions in the chat. So you started your presentation talking about the radiologist workflow and how these algorithms could be better integrated to the workflow. And it almost made me feel like as if the user experience has been overlooked until now, and maybe the performance has been prioritized. And I'm a big advocate of patient-centric healthcare, but also clinician-centric healthcare, right? So regarding the platforms that you mentioned, we have two questions. One from Rachel. She asks about your experience. What platforms have you tried or have you been using in Einstein Healthcare Network? And Kiki is asking, how do you perceive the maturity of the AI platform space, and would you recommend centers to adopt these platforms at this point in time?
Yeah, so regarding where are we, we're just at the very beginning. There are many platforms out there. And the advantages, I think, especially when you're deploying multiple algorithms, is tremendous. If you're just starting out, I don't know that you need the platform to begin with. If you are just starting out with one algorithm or two algorithms, a lot of those issues I talked about only manifest themselves after multiple algorithms have been deployed. But some companies that we collaborate with include Bear and Calantic, AIDoc, Ferrum, Nuance. So those are some of the platforms that we are currently trialing, and that we have relationships with those vendors.
Great. And then we have some questions about the clinical decision support systems. I think it's a very good example that you showed about the pediatric decision support system for to order or not an exam in case of trauma. And we can see that this can be as simple as just a set of rules, or of course can integrate algorithms into it. So Ravi is asking if the purpose of the CDS is to comply with the area under the curve. I think maybe he means if the output should include something about the accuracy of the algorithm.
Yeah, so absolutely. So I guess it depends on your goal for using CDS. I think many people try to put CDS into the system because they were required, CMS was saying, listen, you either use it or you're not going to get paid. If that's the goal, then, the outputs themselves are probably just good enough. But the output, for example, the software that we use actually will give you the actual rating of the appropriateness. So the rating, if you're, for example, using the ACR appropriateness criteria, it's a 1 to 9 scale, and it's broken up into 3, basically, the 1 to 9. There's 1 to 3, 4 to 6, and 7 to 9. 7 to 9 is green, 4 to 6 is yellow, and then the 1 to 3 is red. And so when we get an output, for example, it's using the appropriateness criteria as the AUC. That's the appropriate use criteria we're using specifically in our system is the American College of Radiology's appropriate AC, which is the ACRs. It will actually give you the number. So you can see it usually gives you several alternatives, and it'll give you the rating of each one of those. So you do have that information, and that information should be stored somewhere in your system. Even though the decision support number is no longer necessary from a compliance standpoint of CMS, most algorithms, to my knowledge, still keep a decision support number so that you can back into that instance. So you can go back to your IT team and say, hey, for this instance, what was the original thing ordered? What was the final thing ordered? And you can see all that. So that's the purpose of DSM. So you should still be able to get all that information that you just talked about.
Nice. Yeah, it makes sense. Martin, do we still have more time for questions?
We are unfortunately running out of time, so I think we'll have to close it out. We have more questions, and I actually have a bunch of questions as well, so I think we could probably go on for hours here, but at some point we'll have to make an end. So this speaks to how interesting your talk was, Ryan. Thanks a lot for this presentation. Super interesting. Very happy to have you here.